2025 meeting of the HB 737 Commission for the Study of the Environmental and Public Health Effects of Per and polyfluorinated chemicals. And we're starting with 11 members, which is not quite a full quorum, but we will proceed. And also present this afternoon are Dr. Megan Romano and Will Moyer to bring us up to date on the Merrimack cancer study. And so we will defer a vote on the minutes until later in the meeting if we have a quorum. And I assume that nobody at this point has heard from the Senate President on Ray Brislin's approval or lack thereof. And so that remains an outstanding item to take care of. And so we can now proceed. Dr. Romano.
Wonderful, thank you. Let me get my slide sharing again. All right, can you see my slides?
Yes.
Perfect, thank you so much. Thank you to Chris and the rest of the commission for letting me be here today. I'm really pleased to be here on behalf of the Dartmouth team that recently completed the phase 3 feasibility study in partnership with DHHS. This phase 3 feasibility study investigated the elevated incidence of kidney cancer in Merrimack, New Hampshire, following previous analyses that indicated an increase in cases compared to state averages. The purpose of the study was to gather information to see if it's likely that a future larger study will show whether or not the cancer cases relate to a common cause. And the study employed a multidisciplinary approach involving a steering committee, a community advisory board, and a scientific advisory board to guide its design and execution. Ultimately, it is our hope that a future research study will clarify the potential links between environmental exposures and health outcomes in this region and provide insight for public health initiatives. Okay, so this work was completed in cooperation with New Hampshire DHHS, which included oversight from the Bureaus of Public Health Statistics and Informatics Bureau, as well as Prevention and Wellness and Public Health Protection. Our team at Dartmouth included expertise in cancer epidemiology, renal health and environmental epidemiology, as well as research and administrative support, including infrastructure like the biorepository at Dartmouth Center for Molecular Epidemiology. We also engaged outside experts in qualitative research methods to assist with specific aspects of the overall project. And over the course of the nearly 2 years that we worked on the project, there have been several changes both at Dartmouth and DHHS. So I do want to make sure to acknowledge the hard work of Michael Passarelli at Dartmouth, as well as Michelle Roberg, Leanne Atwell, and Adrian Burke, who did work with us during their time at DHHS to support the steering committee and other aspects of the study. So the phase 3 study focused on analyzing kidney cancer data, included 4 major pieces. The first of those was community engagement. The second was an analysis of cancer registry data. The third was a research feasibility assessment. And the last component was a pilot study. I will review the status of each of these components, but I wanted to give you a sense of the kind of overview and a sense of where we're going. So first of all, we created a community advisory board, conducted community engagement studios, and created an online feedback forum to gain insight into community concerns about kidney cancer and environmental health issues. The second component of our work was the cancer registry data analysis. Here we leveraged the rich data that are available through the New Hampshire State Cancer Registry to understand patterns of kidney cancer throughout the state of New Hampshire and to help us focus on whether there was anything unusual about the excess cases that were previously observed in and around Merrimack. Next, we conducted a feasibility survey in partnership with the University of New Hampshire Survey Center to better understand the willingness of people in New Hampshire to participate in research, what their environmental concerns are, and to understand more about kidney cancer risk factors that are not reflected in the registry data. Finally, we conducted a pilot study to demonstrate feasibility of enrolling study participants and collecting data in support of a future larger and definitive study, and to get a better sense of refinements that would be needed for a larger study. All of these components are summarized in the final report that we prepared for New Hampshire DHHS, and there will be an additional ancillary report on the pilot study once we finish compiling all of the great data that we collected. I will give you a first look at some of that pilot study data today in this presentation. And as I proceed, I will unpack each of these components and both why they were important and what we learned from them. Okay, so for our first component of community engagement, to understand in detail the community's concerns about kidney cancer in Merrimack and the surrounding area, the study team took several steps to engage with community members. These efforts included establishing a community feedback form, creating a community advisory board to represent community concerns and provide insight into the local community, holding discussion groups to identify concerns about kidney cancer and environmental issues. And the team also attended community events and provided regular updates on the study progress to keep the community informed and involved in the study. A big part of what we did was community engagement studios, which are meetings that are designed to get community feedback for cancer research. And they offer researchers the opportunity to consult with the population being studied to improve the research's quality and relevance. These are moderated small group discussions wherein participants are updated on the study background, progress, and plans. They're asked for their perspective on the study, issues in the community, and their guidance on improving and conducting the study. The studios were completed early on in the period of our contract, and they were advertised via multiple channels, including social media, posted flyers, newspaper advertisements, and word of mouth messaging from community advisors. So we made the decision to focus on community engagement in the early months of the project because our team at Dartmouth felt very strongly that understanding the community's concerns about kidney cancer was critical to the success of the project. Because this work was initiated largely because of grassroots community efforts related to environmental contaminants in and around Merrimack, we also wanted to understand community concerns about environmental contaminants. I cannot express enough gratitude to the amazing members of our community advisory board. Several of you are here. Thank you for joining today. They gave us thoughtful and insightful feedback and guidance and were absolutely pivotal to the success of the project. And so I really do want to express the gratitude on behalf of the entire team here at Dartmouth. We have so appreciated working with you and getting your feedback. In addition to that regular feedback from our CAB, as I mentioned, we completed 4 community engagement studios. These took place in June, July, and August of 2024. They were strategically organized across various weekdays and weekends, offering afternoon and evening time slots to maximize attendee availability. We had 30 discussants ranging in age from 21 to 76, with the average age being about 50 that participated in the studios, and 71% of them were women. The majority of participants, about 65%, were from Merrimack, with additional participation from residents of Albany, Bedford, Bow, Concord, Derry, Litchfield, Londonderry, Loudoun, Mason, Nashua, Portsmouth, and a few other places with a handful of folks. The main take-home message from these community engagement studios, and I think the feedback that we got from the community advisory board throughout, was that the community is concerned about the health effects of environmental exposures, in particular per and polyfluoroalkyl substances. They described concerns related to various types of cancers as well, kidney diseases and other serious conditions. And another common concern was about long-term implications of environmental contaminants on sensitive populations, especially children. Many participants expressed a willingness to participate in research studies to better understand the health implications of environmental contaminants. The community members wanted comprehensive studies that not only focused on blood testing, but also considered factors like soil and water quality, specifically in relation to community gardening and food grown locally. They expressed interest in research that will lead to change or action rather than research for science's sake. And we followed up on these ideas in the research feasibility survey that I'll tell you a little bit more about later. The community members also emphasized the need for education regarding environmental risk factors, especially PFAS and its health risks. And participants highlighted that many people either remain unaware of the issues or misinformed about water quality and contamination, suggesting that proactive awareness campaigns could be beneficial in the future. All right, with that, I'm going to transition to the second component of our study, which was the research feasibility survey. Following up on those themes that we heard about through our community engagement early in the project period, we conducted a research feasibility study to dive a bit deeper into some of the potential challenges for a larger study that we had heard about in those initial phases. We completed this component of the study to really gauge how best to conduct a larger study that would speak to the community's concerns and hopefully leverage available resources and expertise. We also wanted to see if the concerns about health and environment were echoed on a larger scale across the state. To accomplish this, we conducted a population-based survey in the state of New Hampshire, the findings of which we have summarized in the final report. The University of New Hampshire Survey Center helped us to implement the survey in November of 2024 to gain insight into New Hampshire residents' views on environmental contamination, potential health risks, and interest in participating in research. A total of 1,183 Granite State panel members, who are a representative population of the adults in New Hampshire, completed the survey online between November 21st and November 25th of 2024. In the survey, they were asked about concerns about environmental issues and health, kidney cancer risk factors, health history, research activities, as well as being given an opportunity to sign up to receive more information about a potential future study. Overwhelmingly, respondents indicated that they would be willing to participate in a future research study and would complete surveys about health and lifestyle, as well as providing drinking water samples. Most were also willing to provide a urine or blood sample. A smaller majority of the respondents indicated that they were concerned about developing health problems in the future because of exposure to environmental contaminants. And the survey also gave us an opportunity to understand more about health habits, including physical activity, smoking behaviors, and cancer history that will be helpful to us in planning a larger study. The third component was the analysis of cancer registry data. The study team analyzed cancer registry data from 1995 to 2021 to understand the incidence of kidney cancer in Merrimack, New Hampshire and its surrounding areas. The analysis, which included additional data versus the prior report and expertise from specialists, aimed to identify potential known risk factors that could explain the previously observed excess of kidney cancers in the region and to identify important subtypes of kidney cancer. The findings do suggest an excess of kidney cancer in Merrimack, New Hampshire, particularly among clear cell renal carcinomas and possibly oncocytic tumors. An excess of kidney cancers in Manchester was also observed. So we'll unpack this quite a bit more. We did this portion of the work to help understand the patterns of excess kidney cancer in Merrimack and the surrounding areas. We also wanted to use all of the data that was available at the time of the analysis, which was the data from 1995 through 2021. We wanted to explore whether all types of kidney cancer were equally affected or if specific subtypes might be driving the associations that we observed. There is an inherent challenge here to working with more than 25 years of cancer data because the cancer classifications have changed substantially in that time period. So one of the big things that we did during this phase was to work closely with the pathologists on our scientific advisory board and the senior cancer registrar for the state of New Hampshire to help us harmonize all of that available data so that we knew we were comparing apples to apples across the many years of data in the study. Now the next bit is going to sound familiar if you heard Dr. Salas and I speak in March, but the commission chair encouraged me to repeat in case folks weren't in attendance. And I promise not to get us too far in the weeds, but I'm going to give a short explanation of the types of statistical tests that I'll be presenting to you in just a couple of minutes here. So to calculate age-adjusted standardized rates, you first need the age-specific rates of disease for each population that you want to compare. This rate shows what the disease rate would be if each population had the same age distribution as your standard population. In simpler terms, you take the real age-specific rates of each population and apply them to one standard age distribution. A common question is whether the cancer rates in a community may be higher than those in other communities or in other parts of the same state. And so in order to answer this, we apply these rates to the age distribution of each community to find out how many specific cancer cases you would expect there to be. Once you have that information, you can compare the expected cases to the actual cases you observed. And this method is often used by state cancer registries to assess cancer trends. One important tool for this kind of analysis is the standardized incidence ratio, or SIRs. SIRs keep track of how often cancer and other diseases occur. SIRs are especially helpful because in small towns, the number of cases for any type of cancer can be quite low. In these cases, age-specific rates can be highly variable due to random fluctuations, making standardized rates less reliable. SIRs help address this problem by using more reliable rates from the entire state to calculate how many cases for a specific cancer might be expected in a community based on that community's age distribution. Now, it's important to understand what an SIR can tell us. Here we'll use an example to illustrate. So consider an SIR of 1.05, where the observed number of cases is 144, and the expected number based on that state average is 137. When an SIR is less than 1, it means that fewer cases were observed than expected, which may suggest that there's a lower risk of cancer. An SIR of exactly 1 indicates that there's no difference, or more simply, that the rate is what we expected. When an SIR is more than 1, it suggests that we have observed more cases than expected, which might be cause for concern. When an SIR like this one, 1.05, is observed, this suggests that town A has 5% more cancer than expected. This could indicate that something unusual is happening in that town in relation to cancer cases, though it may also be due to chance. And so to assess how reliable an SIR is, we use a confidence interval. That confidence interval helps us determine whether the observed increase or decrease is statistically meaningful. That's why both the SIR and the confidence interval should always be considered when interpreting results. So a 95% confidence interval helps us to understand how precise our SIR is and whether the SIR is likely due to chance. If we took 100 different samples and calculated a 95% confidence interval for each one, about 95 of those intervals would include the true value of the SIR. However, in real life, we only take one sample, one random sample, and create one confidence interval. Confidence intervals are useful for several reasons. First, they tell us more than the standard incidence ratio alone, showing the possible range where the true value is likely to fall. Second, if the entire confidence interval is above 1, that suggests that the cancer rate is likely higher than expected. This interval helps us see that while the SIR might be 2, for example, it could also be as low as 1.5, which still indicates a higher rate than expected. Finally, if the confidence interval includes 1, then this may indicate that there's not enough evidence to say with certainty whether the cancer rate is higher or lower than expected. Confidence intervals give us a better understanding of the reliability of our findings and help us avoid misinterpreting small fluctuations in the data. So returning back to our example of the SIR of 1.05, let's consider a 95% confidence interval of 1.02 to 1.08. Because the entire interval is greater than 1, this suggests that the cancer rate is higher than expected and that the result is statistically significant. Now let's consider a different scenario, a 95% confidence interval from 0.95 to 1.15. Since this interval does include 1, ranging from 0.9, less than 1, to 1.5, greater than 1, there's uncertainty about whether the number of cancer cases is truly higher than expected. In this case, we cannot definitively conclude that the SIR is significantly different from 1, which represents no difference. The observed variation could be due to random chance rather than a real effect. Finally, the width of the confidence interval is also important. A narrower confidence interval suggests a more precise estimate, while a wider confidence interval indicates more uncertainty in the data. So looking again at the interpretation of a standardized incidence ratio, an SIR of 1 means that we're seeing the same number of cases that we expect to see, so there's no problem. An SIR of 1.2 means that there are 20% more, I'm sorry, I'm seeing my examples, 1.25 is 25% more cancers than we expected. And an SIR of 0.75 means 25% fewer cases than we expected. If the 95% confidence interval excludes 1, the result suggests a significantly higher cancer rate than expected. So for example, in the previous report, the SIR for kidney cancer in Merrimack versus the rest of New Hampshire in 2009 to 2018 was 1.42 with a confidence interval of 1.10 to 1.81. Because statistics are only estimates of what's happening in the real world based on that single sample, we do want to use that 95% confidence interval to take into context that range of values. So putting this another way, 1.42 is a ballpark estimate of what's going on, but we can also say that the number of kidney cancers in Merrimack is somewhere between 10% and 81% higher than expected. And again here, because 1.1, sorry, my slides are running away from me, because 1.1 to 1.8 excludes 1, we would call this a statistically significant excess in cancer. So in Merrimack in 2022, again, we found this incidence of cancer that was 42% higher than the rest of the state. That confidence interval excluded 1, meaning the result was statistically significant. And that's important because it signals that further investigation may be needed. It doesn't tell us the cause of that excess, but it highlights a pattern that warrants closer examination to determine if additional factors are contributing. Okay, so to summarize, the SIR tells us whether or not there may be an excess rate of cancer, though it does not tell us anything about the cause of that excess rate. The 95% confidence interval aids us in the interpretation of the SIR by giving us a range of possible true values and an indication of the statistical significance. The overall pattern of results is also important to consider. Are several SIRs greater than 1, or is it only 1 or 2? Consistently across findings, when we see this consistency across findings, that can help to strengthen our interpretation. Statistical expertise is also going to be essential for final interpretations because many factors can influence statistical testing and results. Okay, so now let's take a look at the results from our analysis of kidney cancer cases in the cancer registry data. And these have been updated since you saw them last. We, at your request and the request of DHHS, reran these inclusive of the VA cases, which were received quite late. But we were able to incorporate those into these final numbers here. So in our last presentation, we did explain that cancers of the renal pelvis were consistent with expectations across all of the time periods. So here I'm presenting the SIR for all other subtypes of kidney cancers because renal pelvis seemed to be exactly what we would expect. There wasn't a reason to kind of do a deeper dive on that. So here we see that in Merrimack in 2013 to 2021, the SIR is consistent with the previous New Hampshire DHHS report based on the 2013 to 2018 cases of a higher than expected number of kidney cancers with an SIR of 1.38 and a 95% confidence interval of 1.05 to 1.77. This suggests to us, this further analysis suggests that this excess could be potentially important. When we unpacked this a little bit more, looking at the subtypes of kidney cancer, our analysis suggested that this excess may be driven primarily by clear cell renal carcinomas. So that subtype appears to be more common in Merrimack than in other parts of the state. During 2013 to 2021, we also observed a smaller statistically significant excess in kidney cancer cases in Manchester, and this was a new finding. The SIR was 1.18, and the confidence interval was 1.02 to 1.35. This excess is potentially driven by cancers observed primarily among females in Manchester, was something that we found with kind of further analysis. And this does suggest that additional follow-up in Manchester may be warranted given these observations. Since this is the first observation of an excess in Manchester, I'd like to caution against interpreting this too strongly, but I do think that this is something that we would want to follow up on in future analyses and keep an eye on. We did not see strong evidence that traditional demographic risk factors for kidney cancer that were available in the cancer registry, so specifically age and sex, deviated from the expected patterns in our analysis. And very importantly, no kidney cancer cases were reported in individuals under 20 years old in Merrimack in any of the study periods. So the very young folks are not seemingly getting excess kidney cancer in this area. Our final analysis includes several additional steps to thoroughly investigate the excess of kidney cancer. First, we excluded those renal pelvis tumors from our analysis, recognizing that they have different characteristics and causes than renal cell carcinomas. This allowed us to focus specifically on those renal cell carcinoma cases. And this is something that will be very important in considerations for future investigation and for thinking about potential underlying causal agents. Next, we conducted a rigorous review of the reported cases to address issues of duplicate entries for tumors occurring in the same person within the cancer registry. Our goal here was to minimize double counting of individuals while ensuring that we retained cases where cancer reappeared years later or in the opposite kidney or a new kidney cancer occurred of a different type. By refining our methodology in this way, we aim to provide the most meaningful assessment of kidney cancer patterns in this region. So to summarize the key takeaways from this analysis of registry data, we found that the incidence of kidney cancer was 38% higher than expected, with a confidence interval excluding 1, meaning that the result was statistically significant. Additional analyses suggested that clear cell renal carcinoma may specifically be an important driver of this excess. In Manchester, we also found that the incidence of kidney cancer was 18% higher than expected. And again, the result was statistically significant. This is important because it signals that further investigation may be warranted in this area to see if this trend continues over time. Now I want to move on to our final major component, which was the pilot study. Our primary goal with the pilot study was to demonstrate feasibility of conducting a larger study and to help us generate hypotheses around possible causes of the observed excess of kidney cancer cases. It's very important to note that the pilot study does not provide, nor was it intended to provide, any definitive evidence of a cause of kidney cancer. Importantly, the pilot study has generated preliminary data, which will be informative for public health efforts in the state, as well as helpful for pursuing additional funding for a larger, more definitive study. We completed the pilot study to show that people are willing to enroll and participate in a public health research study. Conducting a pilot study, even one that is too small to identify the cause of kidney cancer in the Merrimack region, helps researchers to generate clearer ideas about the potential risk factors for kidney cancer to be explored in a future study. So in terms of our pilot study activities, any adult resident of New Hampshire was eligible to participate, but based on feedback that we received from our CAB as well as from your commission, we preferentially recruited individuals that resided in or have lived or worked in the 9-town area around Merrimack for at least 1 year. Individuals with and without a diagnosis of kidney cancer were included in the pilot study. And this study included a questionnaire as well as sample collection of blood and toenails from a subset of the participants. Our scientific advisory board recommended that we recruit 70 to 100 participants, and the steering committee approved that pilot study plan. We used a wide variety of techniques to get the word out about the study, and boy, did it work, because we had 3,005 responses of interest to participate in our study. These were unfortunately overwhelming deemed to be responses from bots. And this was something that was very important that we learned that will help us when we recruit for the larger study. It will also be easier to verify responses in a larger study with more time and more funding available to do so. I want to say our study coordinator did an amazing job weeding out the real people from the bot responses. She identified 140 valid and eligible participants who were invited to join the study. And among those, 105 enrolled. So we slightly exceeded our enrollment goals of 100 participants, and those 105 completed the study survey. We did have an additional 8 participants who partially completed the survey, but because they didn't finish, we have not included them in the study data moving forward. 9 cases of kidney cancer were included among the participants, which was very encouraging. The prevalence of kidney cancer is about 3%, so we would have expected, if in a random sample of the population of 100 people, to get maybe 3 cases of kidney cancer. So this suggested that our recruitment efforts were useful and would help us to recruit kidney cancer patients into a future study. Just some information about key demographics of the respondents. On average, they were 56 years old, though they ranged from 21 to 87. It was 67% women and 32% men that participated. 41% of the participants have a current residence in the town of Merrimack. 65% of the participants have a public water source and 31% have private water. Among those private well users, 48% have tested for arsenic in the past 5 years, and 45% reported having tested for PFAS. 26% have smoked at least 100 cigarettes in their lifetime, which may sound like a really funny number, but that's what we use often scientifically to sort of designate between a smoker and a non-smoker. And 11% of the participants were current smokers. In terms of what we heard from study participants, 73% were somewhat or very concerned about contaminants affecting farm-produced food. About 2/3 have concerns about that environmental contaminants can affect the health of themselves or their family, wildlife, or cause future health problems. Respondents were generally familiar with contaminants such as lead, PFAS, asbestos, pesticides, and radon, but less familiar with arsenic, PCBs, uranium, cadmium, vinyl chloride, and trichloroethylene. Most were somewhat or very concerned about PFAS and pesticides, while fewer were concerned about cadmium and uranium. 95% of the participants indicated that they would be willing to provide a water sample. Nearly as many, almost 90%, indicated that they would provide a urine or blood sample. That's 87% of the sample for blood sample. A smaller proportion indicated that they would be willing to share their medical records with researchers. This is something that we heard kind of across the community engagement, the research feasibility survey, and in this pilot study, is that folks are generally a little bit less willing to share medical records, typically because of trust issues or concerns about how the data are potentially going to be used or stored, which is very understandable. But again, this helps us to understand what would potentially be more effective research activities to do in the future versus less effective. Among the individuals with kidney cancer that participated in the study, we also asked if they would be willing to let researchers access a portion of their kidney tumor, which is something that's commonly collected during the course of treatment for kidney cancer. So we weren't asking about collecting specifically kidney cancer tissue just for the study, but accessing something that was used in the course of their clinical care. But most of them indicated that they would not be willing to do that. So again, this was helpful for thinking about what types of study activities may be possible in the future. We additionally collected blood samples and toenail clippings. We were shooting to get them from 20 participants. The blood sample that we were collecting used a self-administered finger prick and a microvolumetric sampler. So this was a blood sample that could be collected at home. And we did send those for PFAS quantification. The toenail samples, again, are an at-home toenail clipping. We stored those for potential future use for quantification of toxic metals. Interestingly, we only contacted people who had indicated on the survey that they would be willing to provide a blood sample, and less than half of them actually consented to give a blood sample. So this was interesting in terms of what the actual follow through was for returning the kits. This was a useful exercise, as we were able to get lots of ideas about how we might improve that collection process and response in a future larger study. We also learned, importantly, that we needed substantially more time to accomplish this than we had available at the end of the study period. People had lots of questions, there was lots of back and forth, and to some degree, there was not enough time to sort of engage with the study participants to get them excited about the possibility of providing a blood sample or providing the toenail clippings. I will say people were really weirded out about the toenail clippings, which is maybe not surprising. In my past research, I found that this is usually pretty easy. People clip their toenails, they're throwing them out. We were willing to pay them $25 for their toenail clippings, but it definitely was not something that people were as excited about doing. We did know that one of the participants reached out to us because they had a medical issue that meant that they couldn't provide the toenail samples, and that was another kind of component of this that was interesting. But again, these were all really helpful lessons to learn, and a big part of why we did the pilot study, to really understand what kind of works with this community and what doesn't. Okay. So additionally, in February of 2025, Karen Craver at New Hampshire DES connected the study team with Derek Bennett, who's the administrator of the Drinking Water Quality Program. He manages extensive well water testing data throughout New Hampshire. And Derek created a large data set, including information from private well PFAS analysis that was available in the environmental monitoring database for the 9-town area. This data provided was then compared to the Merrimack Kidney Cancer Study pilot participants' residential history. And the address information that was provided by each participant was searched for within that DES data. What was cool about this was it showed us that it may be feasible to match addresses provided in a residential history to drinking water testing records to help inform exposure models for future research. Making these data ready for use for a research study would require a substantial investment of time and expertise, but we were excited to see that this may be a possible avenue to pursue for future work. Okay, and then just summarizing what we found from the pilot study. So the residents completed the pilot study survey showing that the study methods can be scaled up to a larger study. We do think it's feasible to collect biological samples, but we need a longer time frame, a longer timeline to do that in a more successful way. The Dartmouth team can use findings from the pilot study in a grant application to justify the need for a bigger study in the future through sponsors such as National Institutes of Health. I wanted to say just a little bit about funding of a larger study, although I think I'm running over time. I apologize, Chris. Is it okay for me to? Thank you. Okay. So where does this leave us in terms of next steps? The Dartmouth team currently feels that a larger study would likely require a minimum of 5 years of a timeline to complete, and it would be on the scale of an NIH research project grant. This is also known as an R01 for those of you that may have heard folks talking about NIH funding. This would include about $500,000 per year for direct research costs. We have cast a wide net to consider potential funders, and given that the current climate for federal research funding is very uncertain, we really wanted to think thoughtfully about this during the project period. And so throughout that contract, we really carefully monitored options at NIH, as well as the Department of Defense, the American Cancer Society, and some other foundations to think about what all the different options may be. And we did summarize more details about that in our final report, or I can talk about it a little bit more if folks have questions. By way of background, the R01 is the original and historically oldest grant mechanism used by the US National Institutes of Health. It provides support for health-related research based on the mission of NIH and typically provides 5 years of funding. It does require preliminary data. There are some other mechanisms that don't require that, but this is a big part of why we wanted to use that pilot study to generate preliminary data to leave this door open for us for future funding applications. These applications average a success rate of about 21% at NIH, 13% for a first submission and 33% for a resubmission. Individual success rates are unfortunately lower at the National Institutes of Environmental Health Sciences and the National Cancer Institute, which are likely the places that we would be targeting within NIH. So that is something to bear in mind as we think about this. And just to be sure we're all on the same page about what to expect in terms of timeline, NIH has 3 annual deadlines for grant submissions. The first round of review occurs 4 to 5 months after submission for the standard cycle, and then there's another 4 to 6 months minimum before the project can start if it's successful, which means that there's a minimum of 9 months from the time of application submission to the earliest possible start date for funding. It is typical to have to resubmit an R01 at least twice before it's funded. And we have all heard examples of individuals needing to submit 5 or more times before being able to successfully secure funding for a project. We're being prudent as we can about how best to package this for success, and we have a great deal of expertise and enthusiasm on our team. It is admittedly a difficult funding climate that we are currently facing in biomedical research. You've probably heard NIH has been canceling or rescheduling a lot of study sections and council reviews, and things are uncertain during this current shutdown. So we will continue to monitor the situation carefully and be as strategic as we can in the evolving landscape of federal funding. We all remain very excited about this work. All of the faculty at Dartmouth have donated substantial portions of their time to support the changing needs of this project. We are acutely aware of the importance of the work and very committed to doing the best that we can for the impacted communities. We will keep you posted through DHHS as we make grant submissions related to this work. And we may be reaching out to you for a letter of support or other things as we do that process. We will, of course, let you know if funding is successfully secured and keep you in the loop at that time. In terms of dissemination, we did submit our final report to DHHS on June 27th. They requested some edits for us in August, and those were returned back to them in September. After the contract ended, DHHS asked if we could also create a lay summary of the final report, which the Dartmouth team did do. And both the final report, which is very long and more technical, will be made available on the New Hampshire State Cancer Registry website, as well as this lay summary, which is just 2 pages and quite approachable and friendly, I hope, for everyone. The ancillary report on the pilot study will also be posted as soon as it's available. I did receive the last bit of data that we were waiting for the pilot study today, so we're going to be really actively working on doing that analysis and wrapping up that report. That will also be shared on the New Hampshire State Cancer Registry page when it is available. So just to summarize, key findings. Kidney cancer rates in Merrimack, New Hampshire remain higher than expected. In Manchester, New Hampshire, rates also appear to potentially be higher than expected. The reason for those higher rates is not yet clear. An additional examination of environment or lifestyle factors driving those higher rates appear to be prudent. Community members are generally willing to take part in research, including things like surveys and providing drinking water, as well as blood and urine to help understand the causes of this increase in kidney cancer. We have identified some challenges to moving forward a larger study, but we are cautiously optimistic that this is still realistic within the confines of the fact that the White House budget does include large cuts for scientific research through NIH, which may make it more difficult to secure funding in the short term. And I think that's where I was going to pause for questions before I turn things over to Will.
I have a question.
Please proceed.
Okay. So that toenail thing weirds me out as well. And I guess I never picked up on it. Is there a difference between fingernails and toenails? Why did you go for toenails?
So toenails tend to actually have less contamination because your fingernails come into much more contact with the external environment. You use your hands to do things. You touch lots of different types of surfaces. The time frame of exposure that's represented on a toenail versus a fingernail is also slightly different, with the toenail sort of representing a longer time frame of exposure. And so that's why researchers typically use toenails. We could certainly try using fingernails instead if that feels like less weird to folks. This is one of those funny things that I feel like you lose sight of a little bit as a scientist. So this was very helpful, reality check. And I appreciate you sharing yeah, that is kind of creepy, Megan.
It is weird, but the explanation really helps. So yeah, thank you.
Of course.
Other questions at this point?
Yes, I have a question.
Go ahead, Rick.
Can you? Yes. It's also about the toenail thing.
Okay.
You gave $25. Was that per toe?
No, that was total for 10 toenail clippings.
I'm sorry. I'm sorry. I had to
That's
throw
all
that
right.
in.
We thought that was a very attractive incentive, but apparently still too weird.
Interesting.
If you were going to pay $25 a toe, I would volunteer.
I will bear that in mind for a future study. I don't know if we get that past the IRB, but point noted.
Thank you.
Nancy?
Oh, thanks, Chris. I just wanted to thank Megan and the team for all the work they've done on this, their willingness to collaborate with us here in Merrimack, keep in touch, include us in some suggestions and decision-making around things that we know matter to our community. And to DHHS for way back when I filed this bill to fund it, their advocacy to just get the money to get this off the ground. So it's been a long time coming. We're grateful to see the outcome. Of course, we want more and bigger things and more extensive epidemiological health studies, and we'll continue to fight for that. But this was a key first step, I think, and it was I think it was our pleasure to work together to make it happen. So thank you to everybody who showed up, shared information, got the word out, contributed to questionnaires and all that other stuff. And I think, next time we'll get those 3,000 people that aren't bots.
Thank you so much, Nancy. And I will definitely convey your kind words back to the entire study team. We loved working with you and other folks on the CAB, as well as other members of the community. And it is so important in the work that we do to make sure that your voices are represented.
Other questions or comments for Megan? And we can come back at the end after Will. But I will second Megan and teams at DHHS and Dartmouth, how grateful we are for the work that you've done. In 2016, when we started this, a study was an aspiration. It didn't seem like it could come to fruition here in New Hampshire, but it has, and we're very grateful for the progress that's been made. Thank you.
Thank you, Chris. All right, I'm going to mute myself, but I have Will's slides, so I'm going to drive. Will, just tell me when you want to advance.
Great, thank you, Megan. Right, so hi, so I'm Will Moyer. I'm the section administrator for the Health Statistics and Data Management section in the Bureau of Public Health Statistics and Informatics at the Department of Public Health. I'm going to be talking about the non-kidney cancers. So next slide, please. So for background, the Commission requested that we update the appendix in the cancer incidence report for Merrimack, January 2023. This appendix was just a table showing standardized incidence ratios for selected cancer sites in Merrimack from 2009 to 2018. And in our update, we've expanded this to include the entire 9-town study area combined, as well as each town individually, and to include the same 3 time periods as in the Dartmouth study, which is 1995 to 2003, 2004 to 2012, and 2013 to 2021. And this update doesn't include the kidney and renal pelvis cancers, as the Dartmouth study is doing a much more comprehensive, in-depth look at those. Next slide, please. So here's the top of the appendix from the old report that we're updating. Megan already walked us through what SIRs and confidence intervals are and how to interpret them. So I guess I'll just, the very quickest version is, as the SIR is, increase, that shows an excess, more cases than expected. If it's lower, it's fewer cases than expected. If an SIR is higher or lower, we then look at the confidence interval, because as we know, there's the random variation. We want to see whether it's the increase or decrease is due to this random variation, or if we think that is probably not the random variation. If the confidence interval is entirely above or entirely below 1, then that's an indication that it's might not just be random variation, but there might be something actually going on. And in this one, you can see that kidney and renal pelvis was elevated. And the one thing I'll notice that, thank you, Megan, that in this update, we're doing not 1 table, but 30 tables. I can fit half of a table onto one slide. So rather than showing 60 slides of numbers, I'm just going to try to summarize the results for Merrimack and the 9 towns. The report itself includes the full details for everything, so you'll be able to see that in the report. I just wanted to kind of show the broad overview here. So, and even here, the table was too long to fit on one slide, so I had to cut the table in half. The top half of the table is on the left, the right half of the table is on the right. This is for just Merrimack, showing only the SIRs and the confidence intervals for the 3 time periods, with the higher ones highlighted orange, the lower one highlighted blue. I guess one thing I would like to point out here is that for confidence intervals, basically, as the number of cases increases, the confidence interval tends to get more narrow, which means that when you have less cases, which you'll get for smaller population size, smaller time periods, you can really are only going to detect very kind of larger differences. And so here, and also this is excluding the kidney and renal pelvis, which is why you won't see them here. So here there's only a few statistically significant differences here. I'll point out myeloma, which is on the left-hand table, the second from the bottom. You can see in the 3rd time period that it is statistically significantly elevated at 1.56. However, if you look at the middle time period, it's 0.67. Then the first time period is 1.52. Neither of those are significant. But you can see this is really jumping around a lot. Myeloma is one of the more rare cancers. There's, I believe, the 10 to 20-ish diagnoses in each time period. So this would be a situation where I would say that, yes, in the last time period is elevated, but that's far from definitive, just because of all the variation going on in the earlier time periods. Next slide, please. So this is the same table for the entire 9-town study area. Here you can see there's many more significant results, and this is because this is a much larger population, so there's much more cases. So another thing I'd like to add here is that these are 95% confidence intervals, it's not 100%. And as you look at more comparisons, you're increasing the chances that you still might be getting a false positive with the statistical significance. So again, this is kind of showing a piece of the puzzle, but this is really a kind of a descriptive analysis. Nothing here would be definitive. What jumps out to me is that you can see melanoma is lower in every time period. Beyond that, there aren't too many super clear patterns here. This does also show that it's not that every cancer is elevated in Merrimack or in the 9-town study area. Particularly for Merrimack, it shows that it does seem like it supports the hypothesis that there is something going on with kidney. There's something that might be causing kidney to be elevated. So I'll give you a second to look at that. And yeah, as I said before, I'm only kind of showing a summary for Merrimack and the 9-town study area, but all 30 tables will be in the report one, which should be available soon, I think. So are there any questions?
Yes, I have a question. Wendy Thomas. So we know that PFAS chemicals in general contribute to fallopian cancer, and you've got uterine, you've got ovary, and you've got cervical cancer, but you don't have anything for fallopian cancer. Is that folded into one of those?
I'm not sure offhand. I can confirm that and follow up.
Thank you.
Can you go back to the results slide so we can see that while we're having questions? Please, thank you.
Other questions for Will or Megan? Maureen, go ahead.
Just you may or may not know this. I'm not a cancer epidemiologist by any means. Myeloma being a bloodborne category, does that include things like CLL and those type of bloodborne cancers, you know, we have those acronyms. Is that what is under that broad category? Does anybody know that?
I'm also not a cancer epidemiologist, so I don't know offhand, but I can follow up on that.
All right. I think, because, you know, you don't hear about people really being diagnosed. You hear CLS, CLL, things like that. It caught my eye, the statistics there, because being bloodborne cancer and the way that PFAS, you know, binds to all kinds of things in the blood, and it's hard to leave us. I know they've had an increase in bloodborne cancers in Hoosick Falls, New York. I've talked to residents there many times over the years, and also some folks I know, including my mother, who lived in Cape Cod and didn't know she had pretty chronic PFAS exposure. There's some cancer patterns with bloodborne cancers that I know from her story and from, you know, an activist in New York that many of us have talked with for many, many years. So I would just note that. If anybody wants to just notate that, maybe it's something we can look at a little closer, because I think that's the one that kind of caught my eye. And also the changes in each time period, which is 8-year increments and stuff. In thyroid cancer, the most recent in particular, that is sadly not a surprise. I think with PFOA in particular, you're going to see, my understanding from the literature is kidney is a definitive finding overall, as is thyroid cancer. So I guess with that one, I would like to kind of put out there to anyone who's looking for stuff to do in their jobs. Yeah, that's about screening, right? I think thyroid is a complex organ. We have a vast array of thyroid impacts and parathyroid and all kinds of wonky findings. Anecdotally, by talking to people, I hear it over and over and over, including in my household, where there's no genetic patterns for either of us, and we're, you know, related by marriage only. So thyroid is something that I would like us to kind of think about. How can we encourage people to better screen? Because there's a lot of symptomology that is not recognized as people as thyroid, and it is. And if that isn't tuned into, it doesn't mean a dysregulated thyroid turns to cancer, but it just makes me think of thyroid in large. You know, we've done some work with Megan and the rest of the team on trying to work on breast cancer screening and guidance there, and a couple other things that we're looking at. But I think thyroid is something we really have to focus on from a public health issue, because detection is the key there to not only save lives, but to give quality of life if you treat various thyroid diseases. It's more than just, you know, having a number that's off. It's very complicated around here. So those are just my comments for anybody who's working on these things. Those are things that I think, not just myself, but I would, when I see something, I know that members of the community think in a similar fashion that they would like looked at. Thank you.
John.
Thanks, Chris. Just trying to understand this a little better. I'm looking at the 1995 to 2003 data for thyroid and then for testes, and I see the thyroid's got 1.16, and then the confidence interval is 1.0, 1.34, and then the testes are 1.2, but then the confidence interval is 0.99 to 1.45. So the 1.2 is a higher number than the thyroid, but just is it automatically dismissed because the confidence interval is not a 1.0 minimum, whereas it's 0.99. I mean, you can't get any closer to 1.0. So, and that's not highlighted, but it's a 1.2 value, which is higher than the 1.16 in thyroid. So is that 0.01 confidence interval that precise that it's automatically thrown away?
So I won't say that it's automatically thrown away. And really, the statistical significance is kind of just, you're setting a rule just because you need to make a threshold somewhere. But I think that you certainly could, if you have reason to think that there might be something with testes, you could want to look into that more. the reason why the 1.20, which is higher than 1.16, is not significant would be that I would be almost certain that thyroid has more cases, which allows us to get a more precise estimate of it. Whereas with testes having fewer cases, there's going to be more uncertainty around the estimate.
So this is somewhat subjective as opposed to exact.
So it's not really subjective. I'm sorry, Will, I hope you don't mind if I
No,
jump in
please.
here. But I do think there's a couple of things going on here where we think about the patterns of these results. We're interested in the magnitude. So how strong is it? The direction, is it suggesting an increase in risk or a protective factor? And then we're also interested in the precision. And so part of what I was saying when I was introducing these is that at the end, we have to kind of put some statistical expertise and judgment on all of these things. So I think what you're picking up on here is that aspect of precision is like a light switch. Like it either includes one, it's either 0.99 or 1, and that makes it statistically significant or not. And that is a sort of a binary designation in terms of is it statistically significant or not. But like Will was pointing out, the width of the confidence interval. So if we take, and I'm sorry to Matthew, but if we take 1.34 and subtract 1 from it, there's the width of that confidence interval is 0.34. If we look at the testes and we take 1.45 and subtract 0.99 from it, the width of that confidence interval is 0.46. So that tells us exactly what Will was picking up on too, that it's less precise in terms of what that estimate is. And that can be either because of the sample size, like Will mentioned, or because of the standard error, which is a measure of statistical variation that I will not bore you with. But we want to take all of this together and also consider the pattern of results. I think the other thing to take into account here and to consider is that in the kidney cancer analysis that we did at Dartmouth, we had the benefit of being able to take several months and work with the pathologist and really harmonize the data across all of these years for kidney cancer to make sure that we're counting things exactly the same way across all of these years. And that's not something that we can do for every single type of cancer in every analysis. We would have to have 10 or 15 cancer epidemiologists doing nothing but calculating SIRs all year, every year, to be able to kind of accomplish that. And so part of why we want to be cautious about how we interpret this and this analysis is because we've done so many tests and because we weren't able to kind of add that extra expert layer of pathology on top of it. So, and I just honestly, I want to applaud Will. You did an excellent job. This is a complex set of tables and you did a really nice job presenting it and unpacking it.
Thanks.
Other questions? Amy and then Mindy.
Mindy, were you first?
No, go ahead.
So Megan, thank you very much. And Will, thank you for presenting this. So taking your thoughts one step further, that thyroid confidence interval is about the same size in 2004, 2012 as it is in 2013, 2021. Slightly, slightly smaller than the 1995 to 2003. I totally appreciate the confidence interval, and you've got to draw a line somewhere. But I like the idea of marrying the width of the confidence interval to, what do we do now? Because that thyroid, that 2004, 2012 value is right on the edge. What does the department do? So maybe this is a question for Will and Whitney. Like, what does the department do when you see this? What are the next steps for you as far as the agency that monitors and protects the health of New Hampshire residents?
That was exactly my question and very better stated than I would have, Amy, so thanks.
Oh, okay.
I guess one thing I would say is that at the department, we don't typically or ever really kind of do this very broad sweep of looking at many cancer types for individual towns or groups of towns or counties, just because one thing that Megan and I haven't talked about is the multiple comparison problem, where as you do more of these comparisons, you're kind of guaranteed to get false positive results. So it's unfortunately it's often what has happened is when people have tried to do this, you end up kind of chasing the noise. And I'm sure there are techniques or methods to do this, but we just don't have the capacity to do that. I think Whitney probably has a better answer than me on this. But yeah, it's really I don't think that anywhere really does cancer surveillance this way by proactively looking at everything, just because statistically it's, as far as I know, we don't really have the techniques for that.
If I may, I guess, you know, having found this and understanding that this was a solid methodology at the outset, now what do we do? You know, is it do you wait for another 8 years of data to be able to corroborate this story? I guess I'm trying to figure out, like, if there is something here that could be a threat to the public health, is, you know, where do we go from here? I mean, it seems like to walk away from the 9-town study area wouldn't make sense, knowing, you know, that there is exposure. But then, you know, what are the department's next steps if this has been done and there are some findings of you know, potential concern?
Yeah, I don't have an answer to that.
Can you guys hear me? This is Whitney.
Yes.
Now
Yes.
I can hear you.
Hi.
Yeah.
Oh, okay. Hi. Yeah, I don't know if maybe it would be helpful to have Megan kind of talk through, because really like the next step is what she was talking about at the end of her presentation with regard to taking the data that they got from their study and then trying to access a federal grant to do the next step. So I don't know if that would be helpful to reiterate, because I think that's where the logical next step is.
And that includes this 9-town study area, Megan?
It would include the 9-town study area. I mean, we've been thinking most closely about sort of kidney cancer, but we're also trying to think about how to package it in a way that's scientifically interesting for NIH. And we definitely heard from the community members that there were concerns about sort of broader renal health and thyroid and maybe other types of cancers. And so these are all things that we're kind of taking into consideration and you know, and thinking about what the next step is. And then, you know, in some ways looking at things like biomarkers of renal health or thyroid hormones, you know, those are sort of, I don't want to call them subclinical, isn't the right thing to call them. They're not an overt outcome like a cancer, like a thyroid cancer and or a kidney cancer, but in some ways they're ways to kind of study what's happening kind of earlier in the disease process potentially. And so that is one of the things that we're thinking about is, can we look at more broadly at kind of the health of the population to understand what may be going on in terms of earlier disease processes that may eventually lead to cancer. And I want to be careful, I can't commit us to a specific direction at this point in time, because we're still really thinking about it and wanting to make sure that we, you know, suggest something of an appropriate scope that we can accomplish. But we definitely, this is very interesting. And I think we can, you know, we can consider whether there are additional cancers that might make sense to include in a research study. I think the other thing, I can't speak on behalf of DHHS, but I am also, I'm the environmental health liaison for the Dartmouth Cancer Center. And so I would love to talk to folks more if you think that thyroid screening is something that would be, useful or helpful in the area. I know we have folks that work on thyroid cancer here and would probably be delighted to kind of help think about that a little bit more. So I'm happy to continue that conversation.
Nancy first, then Amy.
Okay, thank you. I just wanted to agree with Amy and Laureen and the points made around concerns around thyroid issues and thyroid cancer. I think one of the things that we discovered as part of the Merrimack Citizens for Clean Water survey, just a survey back in, was it 2017 or 2018, that virtually everybody knew somebody with a thyroid disorder. And I remember going to meet with some physicians over at the what is it, New Hampshire Medical Society back in 2018. And I described this in my own home to one of the physicians there. I said, I have 6 unrelated children. Half my kids are adopted. I was adopted. So really nobody's related to anybody in my house. And I said, I have 4 people with thyroid disorders that are all unrelated. The only thing we share is proximity to St. Gobain, the most contaminated wells that had been serving our home, wells 4 and 5. And, you know, I remember when my son was diagnosed with Graves' disease at 14, the pediatric endocrinologist at Dartmouth said, I can count on one hand the number of Graves cases that I have in the whole state. And, you know, what's the odds that they're showing up here? So I think to the point that, you know, we're seeing these numbers, this has been a long-standing concern. I know of every single one of us from Merrimack. I don't think anybody can talk to a person here that it doesn't either have a thyroid disorder or know somebody within a couple of houses that are dealing with thyroid disorders. So when we see these numbers and we say, you know, okay, you know, they're not sky high, but I think the difference in why it's so important to study it, this particular health outcome, is because we have also had environmental exposure that many other communities have not had. And we wouldn't have guessed maybe 5 years ago that we would see the kidney numbers that we see now. And I think the same. I think we all pretty much feel thyroid is going to be one of those things that we're going to, that's going to bear out some more concerning outcomes as maybe as time goes on. So I would be thrilled to do whatever we can legislatively, work with whatever agencies we have to, but that is, to me, is one of the prime targets that I know, this commission could look into, and the environmentally triggered chronic illness commission. That was a concern for that commission as well. So I'm encouraging DHHS, Dartmouth, however we can collaborate on that, that will be great.
Laureen?
And one of the things that people have felt from the start.
Sorry, Laureen, can I just jump in real quick?
Yeah, go ahead.
All right. It's okay. I just wanted to add too that thyroid is listed as one of the NIEHS, the National Institute of Environmental Health Science. So it's a known known link.
That's exactly what I was going to point out. From the very beginning, Nancy and myself and the others, we were listening to people, we were capturing their data because they needed validation more than anything. And as we were Google searching on phones, we were finding that finding was there. So the frustrating part 9 years later is it still feels like I understand everybody's perspective from a state, agency, from a research, academic perspective, from a science perspective. But I just want to remind folks that from a community perspective, people still feel like we're supposed to go out there and prove something that we know. And what we see is not scientifically, it would be called anecdotal, right? But it's real. It's real. When I worked as a community liaison in the NASM project, I made the point. I focused specifically on thyroid because it's a finding that's been there with PFOA from the very start. It's nothing new. We know our exposure, we know our timeline, we have great data mapping and air modeling and all kinds of stuff that goes back years, right? So we don't need to prove that this has really happened here. We have no real legal rights for our health. They've really been taken away from us in New Hampshire. But what we can do is validate people and help people understand that this is a thing. In my clinical practice in Milford, I see people from many towns. I see a pattern very often of teens and kids with dysregulated behaviors that can be related to and are often related to thyroid that then present as a mental health issue. So this is something that I feel strongly about, and I'm glad we're talking about it. And I'm glad, we saw those slides, because I know Nancy and I immediately were thinking the same thing because we've had these talks. So please, let's focus in, and even if we can do some general guidance for people and physicians, so we can kind of up the awareness, so people can look at this as the reason for why their outcomes. PFAS are the most persistent of endocrine disruptors, right? So it makes perfect sense.
Thanks, Maureen. Mindy, comment?
Yeah, thanks. So just wanted to ask again, just to be sure. So Will, when you guys did this analysis, the comparator group was the rest of New Hampshire, right?
Yeah, that's correct.
Yes. So you didn't remove people who were exposed in the seacoast to polluted PFAS water, which means the comparator group is somewhat dirty, which means that those numbers probably in reality should be higher if you had a clean comparator group of people who are not exposed to PFAS. So unless you pick those out, so that to me, that means that's even stronger, and it's two time frames separated by 10 years. I mean, we know the history of this facility has been operating there for, decades. So to me, those, even though they appear to be borderline, they are actually, in actual fact, they're much higher than that. I would guess if you had the ability to remove Portsmouth residents, all the people that we know have been exposed to PFAS polluted water for a long period of time. So I just want to make that comment and remind Amy, though she might have left, that that is probably even more of a concern.
Okay. Any other comments before we move on? Maureen, go ahead.
Thank you very much, and thank you very much for that presentation. I just want to reiterate, first of all, the importance of the study, and then also how important it was that we were able to fully fund the study in the previous budget. This came through my Division 3 in House Finance, and it passed unanimously, though I do recall some discussion about, a question maybe about participation level. And by listening to this presentation today, you blew that out of the water with 3,000 or so participants. My question is, you mentioned all the ways you advertised it or got the word out to get that kind of response, but did you focus in and ask people, for example, what was it that got you to participate? Was it an ad on Facebook? Was it word of mouth, etc.? Did you focus that closely in on what exactly it was that attracted people or notified people that this was taking place?
So for the pilot study, we did have, we had sort of an initial interest form that people filled out, and that was where we got kind of the flood of responses. And one of the things that we did ask them there was how they, how they kind of found the invitation to participate in the study or to express interest to participate in the study. We have not analyzed that yet. So I don't know, but that is one, we specifically collected it for the purpose that you're suggesting, so that we know, for the future moving forward, if there's one method versus another to target that will help more with recruitment in the long term. We do, part of why we haven't done that yet is we do want to make sure that we remove all of those responses that we were concerned are not real people. And make sure that we're focusing in on just the kind of validated responses that we had. in the end. And that's just, it's not something that our team has had time to circle back to yet, but
Great.
we are planning to do that.
I would just simply say that would be helpful for future funding requests, just in terms of how you notify and the great response you get. Thank you very much.
Thanks for the suggestion.
Thanks. Other questions or comments? I'm just going to wrap up by echoing a couple of things just to tie it together. You know, I definitely see the value in validating through further study, but on the other hand, ultimately, at the end of an 8-year process, the low threshold, low cost response might be clinician guidance and public information. And I don't recall how much thyroid cancer might be addressed in the kidney cancer in the guidance that we have now for clinicians or for the public. That's a low threshold, low cost response. And I think we ought to take a look at it. I'm certainly not the person to look at it, but those who know ought to look at it and make sure that the thyroid disease concerns do have some guidance in both of those documents. There is absolutely nothing wrong with screening and public education and early detection, regardless of what the cause is of those diseases. So with that, I don't know if there's anything else from DHHS. Whitney, if you're on the phone there.
No, I don't think there's anything else for
Okay.
DHHS.
Thank you very much. Thank you, Megan. Thank you, Will. Excellent presentation, and hope we see you back in a few months. Andy Fuller, you were somewhere.
Hi, everyone. Again, my name is Andy Fuller. I'm in the Hazardous Waste Remediation Bureau of Waste Management Division, a project manager for the St. Gobain Performance Plastics site. I'll be providing the DES update for the commission today in place of Director Wimsat, who was fortunate enough to have a nice long extended weekend off. So quick update for the Air Resources Division. They are currently in the process of terminating the air permit held by St. Gobain for the operation of the facility and their air pollution control equipment. On to facility closure. As everyone's aware, St. Gobain has been working to decommission their former facility since the second half of 2023 when they notified DES of their intent to restructure their composite solutions business in the United States. That included the removal of all the machinery, the buildings, and materials from the area of the former facility. As of September 24th, the demolition of the building is considered complete. The milestone was reached when the final length of sewer pipe was addressed in the area of the railroad where it meets the town sewer main. The fencing and cameras will remain at the property for security, and St. Gobain's indicated they'll be providing a final demolition decommissioning report documenting that effort. They've also been conducting their ongoing evaluation for the potential of leaching of PFAS from the concrete slab that remains at the site. That's being completed following the EPA LEAF methods and guidance, and also through a simulated rainwater runoff test. Results from that leaching analysis are going to be provided separately from that decommissioning report. We expect the decommissioning report relatively soon, but the leaching study is going to lag behind a few months. I believe they're just getting some of the results in for that. So, for the Waste Management Division, their contractors have continued installing POET installations for residents within the consent decree outer boundary. At this time, all residents eligible for POETs up to attachment 27 have been notified. And as of October 1st, they've installed approximately 758 systems. And of those systems, 716 are considered complete based on the requirements for the running of the system for a certain number of weeks and the sampling to test to prove to show that they are definitively removing the PFAS. St. Gobain's contractors have also been completing the periodic maintenance of those systems in accordance with the work plan. We have a report from May this year that summarizes results of the POET installation effort and associated system monitoring. We'll be completing our review and providing comment as needed on that. St. Cobain's continued construction for municipal water connections throughout the consent decree. That would include areas with existing water lines where homes required connections to the mains in the street, and then areas where new water mains need to be installed. Work's been conducted by various contractors depending on the area and the utility provider. And since the start of construction, they've connected approximately 160 properties to municipal water. That includes 28 properties in Bedford, 71 in Litchfield, 13 in Londonderry, and 48 in Merrimack. For some of the more recent term sheet attachments, which includes 23 through 27, that includes about 15 properties for proposed municipal water connections. St. Cobain's been able to tie some of those into existing contracts, and then there's a few where they've had to issue new contracts to complete that work, but they tend to be continue those. St. Cobain's continuing to work with the water utility in the town of Londonderry to evaluate the feasibility of the water line extensions in that town. We've met with St. Cobain and the town and the water utility multiple times to discuss the expanded service in this area. As we've notified before, Londonderry has also been approved by the Drinking Water Groundwater Trust Fund Advisory Commission for an $8 million grant to supplement the town and St. Cobain's contributions to the larger project. This includes a project that's currently underway by the town of Londonderry that's going to extend municipal water from up High Range Road from the Route 102 in the south to the area of Royal Lane. Negotiations between the town and St. Cobain continue for the area north of there, and we're hopeful that agreement will be reached soon. We periodically receive updated proposals from St. Cobain for additional water supply wells within the consent decree following the initial agreements from April and June of 2022. We are now up to term sheet attachment 27 that was received and reviewed by DES in September. We expect attachment 28 to be submitted in November. For water supply well sampling, they have continued long-term monitoring of drinking water wells under the groundwater management zone work plan to support the implementation of a groundwater management permit and the supporting groundwater management zone. In general, that work plan proposed to conduct sampling so that by the end of 2026, there will be 6 PFAS sample results for each property that's eligible for that sampling. As of October 1st, they've sampled nearly 1,400 properties that were eligible for monitoring under that work plan. And they continue to sample approximately 150 to 200 properties per month to maintain the requirements of that work plan. They submit bi-monthly status reports on the sampling effort, and properties that exhibit exceedances of the state drinking water standard continue to be issued bottled water eligibility letters. Since the start of the sampling in January, there have been approximately 159 additional properties identified exceeding the AGQS for PFOA, and they've been offered bottled water by St. Cobain. There have been previously unsampled areas within the consent decree. DES had consistently expressed the need for additional sampling addendum by St. Cobain to complete that sampling. They had continued to decline, so as I've indicated before, DES has been conducting sampling of the remaining homes within the outer boundary that St. Cobain hasn't offered to sample yet. We targeted approximately 88 residents. We were able to sample 88 properties as part of that effort. And of those results received, about 22% of those exhibited an exceedance of the New Hampshire AGQS, and 70 exceeded the EPA MCL for PFOA. Recently in July, however, St. Cobain has proposed to sample some of the previous unsampled areas within the towns of Bedford and Litchfield. These tend to be focused in areas near the edge of the CD outer boundary, where they had refused to sample previously, and they're also in areas where there aren't any other, where they have stated that there aren't other potential sources. They're not near fire stations or landfills. We approved that work plan with some comments, and then they intend to be sampling those properties twice before the end of February 2026. On the site investigation and remedial action plan side of things, the RAP and Rapidendum have been submitted to DES. We determined that both of those didn't meet the requirements of ENVR 600. Deficiencies were outlined in a letter to them. Their consultant identified data gaps that they said need to be addressed in order to respond to our comments in the letter and prepare a revised RAP addendum. St. Cobain submitted a work plan for the additional data that they needed to collect. We approved that work plan, and that work is expected to be performed later this fall. As we've discussed before as well, we were contacted early this year by the property owner developing the parcel at 702 DW Highway, which is located across the street from the former St. Cobain facility. The property owner had provided results of soil testing on the property identifying PFAS contamination, and had also generated a soil pile that cannot be reused on site due to space limitations. We believe that this contamination is the result of releases from the St. Cobain facility, and we sent St. Cobain a letter to that effect. We have been recently informed by the developer that they propose to purchase the adjacent parcel to their property and use that space to place the excess soil generated as part of the project. We received that proposal from the developer for this effort, and we issued an approval letter to them at the end of September. After that soil has been moved to the property and stabilized, seeded, and all of that, an activity and use restriction will be recorded as the property deed just to provide notice that that soil is being placed there. We also received notice earlier in the year that the town of Merrimack was developing plans to replace the US Route 3 bridge across the Babusick Brook as part of that project that also realigns Wire Road at the US 3 intersection. Based off of the initial discussions with the town and their project team, there was the potential to generate a significant volume of soil that couldn't be reused in the vicinity. However, we recently received notification from the town that they have changed their plans and they're for that project and will not be generating any excess soil. Both these are, pretty significant, and they highlight the need that following the development of our soil remediation standards for PFAS and all this development within the outer boundary, we really need additional data to quantify the distribution of PFAS in soil resulting from emissions from the St. Cobain facility and guide management of soils within the outer boundary in a manner that's protective of human health and the environment. We have requested that St. Cobain submit a work plan to evaluate PFAS distribution in soil within the outer boundary. We've requested that work plan be submitted by the November 7th of 2025, and we anticipate the results of that soil sampling effort will be not only refine the understanding of the nature and extent of impacts resulting from their releases, but ultimately be used to kind of develop guidelines for soil management practices within the outer boundary as development projects continue to occur and come in. That wraps up most of my update for BES. I don't know if there are any questions.
Yes, I have a question. This is Wendy.
Go ahead.
Yeah, so you've talked about St. Cobain is responsible for putting in a lot of POET systems. We've talked about this several times, and I've never gotten any sort of definitive answer on it, but shouldn't they also be responsible for responsibly disposing of the spent filters from those filtration systems? And has anyone ever approached them about that?
Well, they are responsible for maintaining the point of entry treatment systems that they've installed. So they go out and periodically test those systems. They also have to do carbon change out when there's breakthrough on those systems. So at that point, they're also paying for the disposal of the carbon that's considered spent. So.
Okay, thank you.
Mm-hmm. Don, go ahead.
Yeah, real quick, Andy, you mentioned that Hudson received a grant for $8 million, and that was to augment, I think what you said was that was to augment some of the waterline extensions that St. Cobain was already paying for. Is that correct, what I heard?
It's slightly different wording. I wouldn't put it that way. It was Londonderry for one, and Londonderry have, obviously their contamination from St. Cobain extends, beyond the consent decree outer boundary in all the towns, but in particular Londonderry too. So they'd obtained that grant in order to provide municipal water up High Range Road and outside of the CD outer boundary. So they're running that. They are not paying for any water lines within the consent decree outer boundary. Those are the responsibility of St. Cobain. St. Cobain had proposed a water system kind of on the northern end of High Range Road. And then they had more point of entry treatment systems to the south of that Royal Lane area. So this was basically, the town saying, well, we're going to come up from the south, and we're hoping that what we can get is that water line can continue up High Range Road to basically connect to Manchester.
Yeah, I guess I just wanted to confirm that Saint-Gobain wasn't paying directly for water line installations beyond the consent decree boundary, because that obviously would establish sort of a precedent that we haven't seen before. But I misheard what you said, so I apologize. Thanks.
No, that's okay. Like it's there's some synergy there in that the town wanting the water line and Saint-Gobain needing the water line is really what it boils down to. But the town has several projects outside of the consent decree that require that municipal water. So I believe that not even any of the properties on High Range Road will be connected to that water line until they finish. They have a large development that's going in called Woodmont Commons. And I think that has to be connected before they're going to start doing connections along High Range Road anyway. But they would be outside of the consent decree that the town's working on them anyway.
Okay, thanks.
Nancy?
Yeah, Andy, can you tell me again? I don't think I heard. Where did the funding come for that $8 million for?
It was approved by the Drinking Water Groundwater Commission Trust Fund. I'm not sure exactly where those pots come from. But.
Okay, thank you.
Other questions for excuse me, Andy? I don't see any, and so let's move on to legislative update. Maureen, thank you for compiling the list of LSRs, and we have 2 members of the commission who do have LSRs pending, so we'll ask Nancy and Wendy to speak to those items.
Sure. Nancy, I can go first if you want.
Yep, go ahead.
All right. So I have two LSRs that deal with PFAS. One is a consumer product ban on condoms and personal lubricants that contain PFAS. So as we do in New Hampshire, we don't ban anything unless there's a safe alternative, and there are many safe alternatives. So they're in my research, but I need to look into it deeper. There's one brand that measures high amounts of PFAS, and one type of Trojan condoms so it's not Trojan, it's not the entire brand of Trojans, it's just one type. KY jelly has really high PFAS in it, and there's some also anal lubricants that have PFAS as well. So this is not, it's trying to be spun as I'm trying to ban condoms in New Hampshire. No, I'm trying to ban consumer products in New Hampshire that are detrimental to our health. So that's one of the first bills. The second bill is anticipating that we would get awards for PFAS legal settlements, is to set up a fund for farmers to help them if they find out that their land is contaminated with PFAS. They're going to have extraordinary bills like overnight. So if you've got, just to use as an example, if you've got a herd of cattle or a herd of dairy cows or something, and you find out that the field that they're eating from has been contaminated with PFAS sludge, that farmer's got to buy clean hay overnight. I mean, so it's an extraordinary expense. And we have to protect our food, and we have to protect our farmers. So the bill would ban sludge in New Hampshire because there is no safe limit for sludge. There's no sludge that doesn't have PFAS in it. So the bill asks to ban sludge. And we're not even going into the other contaminants in sludge, like the pharmaceuticals and the organic stuff. We're not doing that. We're just focusing on PFAS because that's what people can understand. So a committee would be set up to, just like the water fund, to sort of allocate money to the farmers. We don't know, in Maine, they've set a standard that if a piece of property, a farming property, is so contaminated, and I think it's very low for them, it's like 6 point something parts per trillion, that then the state actually purchases the land. And I pushed back on that, and I said, well, we can't just keep buying land around. But in Maine, what they do is they then lease that land to growers of crops that are non-edible, and an example of that is Christmas trees. So a Christmas tree farm could be grown on PFAS contaminated land. So there's a lot to figure out for this bill. It's very complicated, but it's been submitted. So we'll see.
Thank you.
Okay, and I submitted actually a bill that I had submitted formally in 2024. At that time, it was HB 1415 relative to PFAS facility liability. And in essence, this bill would hold polluters accountable, polluting facilities accountable upon closure, removal from service, or decommissioning for all everything inside the building, everything outside the building, tanks, piping, containers, manufacturing equipment, wastewater treatment infrastructure, air pollution control devices, anything that was used to handle, convey, or otherwise manage materials or waste containing PFAS. And according to federal guidelines, at that time, Sarah, you as current Assistant Director of DES Waste Management, spoke in support of the bill. And we passed it in the House, we passed it in the Senate, and Governor Sununu vetoed it. We were able to overturn it still in the House, but not in the Senate. And I think it still has value. I think it's one of those things that we may not have a ton of facilities that, big corporations or industries like Saint-Gobain, but there are enough of them. And, we're looking at, just like, I think was mentioned earlier, the foundation up at PFAS, at Saint-Gobain. You know what, that's still on the ground. It's striated, but, like in my mind, that should be gone. And so anyway, we filed this bill. We have a new LSR number, and we'll see. We'll see what the will of the House and the Senate and the governor are.
Amy? Amy? I muted myself.
Yes, sorry, Nancy, is that language that you can send around to the committee, or would we find it online, or? Oh, you're.
Yep. Actually, if you just look up New Hampshire HB 1415, 2024.
1415, thank you.
Yeah, and I, I'm gonna, excuse me, I'm gonna meet hopefully with Mike at some point in the next couple of weeks. I'll reach out to see if we need to change anything in this, but I think the intent is still the same.
Maureen, go ahead, please.
Thank you. So at this point, to my knowledge, no LSRs have bill numbers or published texts yet, but I will continue to update the chart that I sent around today. And secondly, veto day for this year is scheduled for December 17th, and no PFAS bills on that small docket of 10 bills will take up on that day.
Interesting. Okay, thank you. And there's one other LSR we haven't talked about, which is 2790, sponsored by Representative Dale. I don't know if anybody knows what that one is about. It's hard to tell from titles alone. Okay, I'm sure we'll find out soon enough. Thank you, Maureen and Nancy and Amy, Wendy. So at this point, we did achieve a quorum very soon after we started. So I'd like to go back to approval of the minutes of the September meeting, which Representative Donnelly kindly completed. I will note for purposes of a vote, anyone present here who was not present in September as an abstention. And with that, are there any questions or comments or objections? Rich, if that's you, could you speak up, please?
That wasn't me.
Okay. Does anyone have an objection to approval of the minutes? I do not hear any, so those will be approved with abstentions noted. And just a reminder that the annual report is due November 1st. I will take care of that. If there's any other input on that, please let me know. Unless there's other new business, I'll just announce our next meeting is November 14th, Friday at 2 p.m. And if there's no other business, I will take a motion to adjourn.
So moved.
I'll
Was that
second it.
Moved by Nancy, I believe, if I recognize voices, and seconded by Amy. All those in favor, please indicate aye. Any opposed? All right.
Aye.
Have a
Chris,
good long weekend, everybody.
Chris, I think am I note taker for next time?
Yes,
Okay.
Okay.
Thank you.
always a
All
yes.
right.
Thank you.
Thanks,
Thank you for
everyone.
volunteering. Take care.